Presentation, challenges, and pitfalls in head and neck pathology. Lesson learned from case example in my practice.
Good morning, everybody. First, I would like to thank the organizing committee for inviting me to present my talk here today. I have been visiting Vietnam for many times, and each time I have been very happy because the warm hospitality from all of you. Yeah, today I'm gonna talk. Actually, my topic is quite very similar to Professor Angela Chong. I'm also doing practice in head and neck pathology, and I would like to share my interesting case from my own experience to you today. Okay. So my topic is challenges and pitfalls in head and neck pathology, lessons learned from case example in my practice. I have no financial relationship to disclose. This is the hospital where I used to work. I just retired from the hospital 2 months ago. This is called King Chulalongkorn Memorial Hospital. The hospital belongs to Thai Red Cross Society, which is a non-government, non-profit organization, and has been founded for 100 years. Okay, the hospital is affiliated with Chulalongkorn University. That is the public university. So in my work, I work for 2 organizations. One is for Chulalongkorn University. The other organization is Thai Red Cross University. Okay, so my aims of my talk today is want to share interesting case that good to be a lesson for everyone today. My topic will cover some oncocytic lesions and the tumors that come from that located in the unusual size, and some example of cytopathology and core needle biopsy specimens. Okay, so case number 1 is a 67 years old woman presented with right parotid mass. So this is the morphology of this case. This is from the parotid gland, and you can see the tumor has quite well defined nodules, but they have a lot of they have multiple nodules, and from the low magnification you can tell that this is the oncocytic tumor. Here, look closely, you can see almost every cells look like oncocytic cells. But there are small areas, very scanty part that there are other cell components, which is to me it looks like the mucus producing cells. So what do you think this is? What do you think the diagnosis is for this case? Okay, so I did some spatial stain, musicamine, which is positive, especially in the glandular area and in the cell that look like mucus secreting cells. And the cells are also positive for CK7 and P63. Okay, so the diagnosis in this case is leukoepithelioid carcinoma, oncocytic variant. Yeah, this is the lesson that I would like to share with this case. Yeah, for oncocytic variant of leukoepithelioid carcinoma, it is very easy that you may misinterpret as it is as an oncocytic tumor, because oncocytic tumor is a common tumor in parotid gland, salivary gland. So what the different thing is that in oncocytic tumor you will see only oncocytic cells, totally oncocytic cells in the tumor. But in leukoepithelioid, even though most cells are oncocytic, but when you see other cells that are typical for leukoepithelioid carcinoma, yeah, that is the different. That is the clue and the important point that you can make diagnosis for leukoepithelioid carcinoma. So leukoepithelioid carcinoma will consist of different cell type: mucus cell, epidermoid, intermediate cells, and the marker will be positive for high molecular weight cytokeratin, such as CK56 and also P63. But for the oncocytic tumor, they are not positive. They are negative for these markers. P63, mucin also negative. So these are the distinguishing features between these two neoplasms. Okay, next is second case. This is a 46-year-old woman presented with a thyroid mass. This is another oncocytic lesion. Here is the tumor. I just show you the tumor. It arises in the thyroid gland. So the tumor also look like oncocytic cells, but the key features here in this case, the border of the tumor is quite infiltrative, and you can see entrapment of skeletal muscle, and the tumor cells look pink and granular cytoplasm. And the tumor, aside from involvement in the thyroid gland, it also extends to the surrounding soft tissue. So what is the diagnosis? Anyone want to guess? What is the diagnosis for this case? So since it is unusual features, we stain for thyroid marker, PAC8, TG, and TGF1 all were negative. Okay, and they are positive for S100, CD68, and SOX10. Okay, so diagnosis is granular cell tumor. So granular cell tumor is very rare, especially in it is common in other sites, but for thyroid gland, this is a very rare tumor. I have seen 2 cases in my experience. The most important thing that that will be a clue for you is the infiltrative border. Perineural invasion is also important. As you know that granular cell tumor arise from Schwann cells. So it is very common for this tumor to show nerve involvement, which is not criteria to call it malignancy. You can see benign granular cell tumor with nerve involvement. This is common. So the most helpful feature that make you think of this tumor, aside from oncocytic tumor of the thyroid gland, is the infiltrative border. You will not see infiltrative border in the thyroid oncocytic tumor because oncocytic tumor, regardless it is benign or malignant, the nodule always have a demarcated border. But with this tumor, granular cell tumor, it always have an infiltrative border. So this is the difference. As I have mentioned, infiltrative border is the key features. And also the arrangement. For oncocytic cell neoplasm, you will see follicular cell arrangement. But for granular cell tumor, you will not see the follicular cell pattern. And the when you suspect for this tumor, you can do immunohistochemistry with S100 SOX10. Also, inhibin and carotene also positive for this tumor. And for PAS also, PAS with diastase resistance also be present in granular cell tumor. These granules come from lysosomes in electron microscope examination. But the granules of the oncocytic cell tumor are from the mitochondria. So this is the malignant criteria for this tumor. You need at least 3 of these features to call it malignancy. Nuclear pleomorphism, cell spindle, mitotic figures, more than 2 mitosis per 2 millimeter, supramillimeter, prominent nucleoli, high NC ratio, and necrosis. But if you see only 1 or 2 of these criteria, you can call it just a typical granular cell tumor. Now we go to the next case. Case 3 is a 42 years old man with upper gum mass. So now we move to the tumor that is present in unusual locations. So this is the tumor of this case in upper gum. You can see the tumor infiltrate into the subepithelial stroma, and it looks quite similar to squamous cells with polygonal shape and high pleomorphism nuclei. And in this case, it also shows bone invasion. But there are a few areas that show clear cells. These clear cells have vacuolated cytoplasms. Okay. Anyone want to guess what is the diagnosis for this case? Okay, so we did immunohistochemistry. This is EMA, androgen receptor, GATA3, and adipophilin. Yeah, this the adipophilin has a very typical staining pattern, which is membranous multi-vacuolated pattern of staining. So this case is diagnosed as sebaceous carcinoma, which is quite uncommon because sebaceous carcinoma, as you know, it is a tumor of skin lesion. But in this case, it arises in the oral cavity. So sebaceous carcinoma in the oral cavity has been reported. Only 15 cases are reported in the literature, not including this case. The most common area is the buccal mucosa and lips. And actually the morphology for this case is not difficult, but because of the unusual site, in the first in the first time I was not confident that this is sebaceous carcinoma because I have never seen any case of sebaceous carcinoma in the oral cavity. However, because the morphology is quite obvious, so I confirm it with the immunohistochemistry and conclude the diagnosis as sebaceous carcinoma in oral cavity. So this is the difference. Sometimes sebaceous carcinoma, if you don't see the typical feature, sebaceous differentiation, it looks very similar to squamous cell carcinoma. It can show squamous differentiation, it can show keratinization, but the immunohistochemistry are different. Sebaceous carcinoma are positive for EMA, were EP4, AR, androgen receptor, GATA3, CK7 also, and adipophilin. While squamous cell carcinoma are all negative for these markers. Now we go to case number 4. This is a 60, still in the tumor found in an unusual locations. A 66-year-old man presented with an ethmoid sinus mass. So this is the morphology of this case. When you look closely, it is unusual morphology. You cannot think of any typical tumor of this location. The tumor have a solid pattern of growth, and some area they look a little bit trabecular pattern. It doesn't move. What do you think that is the diagnosis for this case? Since it is unusual morphology, when you dealing with the unusual morphology, one possible diagnosis that you may think of is the secondary tumor. So I go back and review the medical record. This is a good thing that when you work in the hospital, you always can have a past history of the patient. And I saw the OPD note of this patient. The doctor suspected that the patient had a C pancreas with liver metastasis. That means there is a liver mass and pancreas lesions. But with morphology like this, I think maybe liver is more possible. So I did immunohistochemistry, AFP positive, arginase 1 and hepatocyte 1 positive. So this is the metastatic hepatocellular carcinoma. Okay, so we go to the next case. This is another unusual size tumor. A 36-year-old man presented with right maxillary sinus mass. Here is another. So when you look closely, this tumor have a little bit granular cell differentiation, but it is also unusual morphology that you cannot match with any specific type of ethmoid sinus tumor. So again, I go back to review the past history of this patient and found out that this patient used to have a bone fracture of the humerus, and the bone fracture was biopsy. The bone that bone was lesion was biopsy, and it turned out to be metastatic follicular cell carcinoma of thyroid, which is actually I did not show. I did not take a picture of the bone lesion, but it's more typical for follicular thyroid carcinoma. But in sinus, I don't see any follicular cell differentiation. But anyway, because of the history, I go on for investigation. So the tumor are positive for PAC8, TG, and TGF1. So this is a metastatic thyroid carcinoma, which I think is the same lesion with the bone lesion, thyroid follicular cell carcinoma. And there's no nuclear feature of papillary carcinoma. So I think this is a thyroid follicular cell carcinoma. So this is the lesson that I learned. When you have you see any unusual morphology of the tumor in any location, always think of secondary tumor, and just go back and review the medical record, medical history, and you need immunohistochemistry study to confirm your diagnosis. There's one article, one series review metastatic tumor to sinonasal cavity. This series had GI tract. Is the most common primary tumor that metastasis to sinonasal tract with 27%, followed by liver, like in our case, and thyroid and breast are the third common, the third most common tumor that metastasis to the sinonasal tract. Now we go to case number 6. Still tumor in unusual size. A 54-year-old woman presented with a right thyroid mass. So this is the gross appearance of this tumor. You can see the lesion has unified infiltrative lesions in the thyroid lobe, and they have a firm gray-white cut surface. So this is the tumor. When you look closely, it looks like undifferentiated carcinoma, some kind of undifferentiated carcinoma. Yeah, that made me think that this tumor may come from other sides at the first time, like for example, nasopharynx. It looks very similar to undifferentiated non-keratinizing carcinoma. So I did investigation to rule out metastasis from the nasopharynx, and EBV was negative for this case. So there's another possibility when you see this morphology, undifferentiated carcinoma that present in the thyroid. One possible diagnosis that you have to think of is the thymic carcinoma, intrathyroid thymic carcinoma. Then I did the immunohistochemistry, and it turned out to be intrathyroid thymic carcinoma. The tumor are positive for CD5 and CD117. So this is a good example of intrathyroid thymic carcinoma. which the clue is the morphology look very similar to undifferentiated non-keratinizing carcinoma of the nasopharynx. Okay, so actually I think the first impression you must think of is intrathyroid carcinoma, and then if it's not, you can rule out metastatic undifferentiated carcinoma later. But the first diagnosis you should think of intrathyroid carcinoma if you see this morphology. Okay, yeah. So lesson learned from this case that is whenever you see thyroid cancer that look like non-keratinizing undifferentiated carcinoma of the nasopharynx, always think of intrathyroid carcinoma. Okay, next I will show you the pitfalls and the challenges of the choroidal biopsy specimen diagnosis. Recently, I received the choroidal biopsy of thyroid gland very often, and luckily they always usually send submit together with the FDA cytology, so I can compare the slides cytology and histology. That made me have advantage in interpretation of these cases. So this is choroidal biopsy of thyroid gland. So you can see there are two areas. One is the benign area, look very benign, and the other area look quite different, quite contrast to the benign thyroid. Yeah. However, when you look at the morphology, especially the nuclei of the cells in the atypical area, the cell, the nuclei look quite uniform and round in shape, and they are dark staining. They're not contrast because when you see in the low magnification, the arrangement is a little bit resemble papillary thyroid carcinoma in this case. But when you look at the nuclei, they look not typical, not typical for papillary thyroid carcinoma. But when you look closely, you can see intranuclear inclusion and nuclear grooves. So this is papillary thyroid carcinoma. So what I want to emphasize in this case, for this case, is that when you get the core needle biopsy specimen, be careful, because the core needle specimen, you may not see the typical chain of nuclei of the papillary thyroid carcinoma as you see in the surgical pathology specimen. So this is one paper explore this issue. They compare the core needle biopsy specimen and the surgical biopsy specimen, both in the papillary thyroid carcinoma samples and both for the follicular epithelial cell sample. So you can see that the size of the nuclei are really smaller in the core needle biopsy specimen on the table above, upper table. On the lower table, they use the criteria of PTC nuclei proposed by NIPP group, the three score criteria, and they found out that the core needle biopsy usually have a lower score, compared to the PTC surgical specimen. So this is, I think it's about the process. It comes from the process of the preparation. So this is another pitfall, especially when you have a small biopsy, corneal biopsy, and you don't have a benign cell to compare like this case. So you can make you can be confused with benign lesion. So be careful. Yeah. So anytime that I talk about papillary carcinoma, I always show little orphan Annie eyes to the audience. So this is the cartoon debuted in 1927. So I think most of you in this room may not born yet in that time. Yeah, I'm sure. I'm not. Okay. But to me, orphan Annie's eyes may not correspond to the real papillary thyroid carcinoma nuclei, because the orphan Annie's eyes are empty, totally empty. But in the reality, papillary thyroid carcinoma is not empty. The nuclei of the PTC, they have like gall glass appearance. They have chromatin. So it is not empty. Anyway, pathologists like to compare things compare the morphology with other things to be better understand the disease. Now we go to case number 8. This is FNA cytology, the case of FNA cytology. 63-year-old male with left submandibular mass. So this is the tumor cells. You can see the tumor cells look very dispersed, look very loosely arranged, and some cells may have a vaguely plasmacytoid appearance and a little bit spindle cells. Some have a basaloid appearance. So at the first diagnosis, my diagnosis, I suggest this case. We didn't see. I didn't see any myxoid matrix in this case, but with the morphology, I suggest this case as a pleomorphic adenoma, because the tumor had a very the morphology looked very similar to myopithelial cells. But when the surgical specimen followed, it turned out to be adenoid cystic carcinoma for this case. So this is another mistake that I have made in my experience because of the morphology. Yeah, there is perineural invasion. So this case turned out to be adenoid cystic carcinoma. So what we can learn from this case, this is the comparison on FNA cytology between pleomorphic adenoma and adenoid cystic carcinoma. In the typical case, I think not this case, but this case is quite challenging. For the typical case, for pleomorphic adenoma, you have architecture of a loose sheet and syncytial with ill-defined borders or fuzzy border. While for adenoid cystic carcinoma, usually the tumor will come with three-dimensional cluster with a sieve-like structure, like a cribriform appearance. I will show you the pictures later. And the matrix, for the matrix of the pleomorphic adenoma, usually matrix of pleomorphic adenoma is fibrillary myxoid with indistinct border. While the matrix of the adenocystic, they are usually spherical in shape and have sharp border. For the cells, the pleomorphic adenoma usually have a spindle cell or plasmacytoid appearance, while adenocystic carcinoma have a basaloid appearance. And the cytoplasm for adenocystic, you have a very scant cytoplasm, while the pleomorphic adenoma cytoplasm may be more in amount. So you can see the comparison on the left side. It is an adenocystic carcinoma. So usually it comes with a three-dimensional cluster of cells with a very nice spherical matrix, which represent basement membrane materials. While for pleomorphic adenoma, the cells usually have dispersed, loosely adhesive cells, and the matrix are fibrillary with ill-defined borders. But for this case, you can see on the left side, they look very typical for pleomorphic adenoma, with plasmacytoid appearance, with spindle or ovoid nuclei, which are very typical for myoepithelial cells. Actually, both are myoepithelial cells, but they have different morphology. Yeah, so the lesson learned for this case, you must not jump to the conclusion when you don't see the full criteria for this case. Yeah, because this case, I did not see the myxoid matrix. I should not make a diagnosis conclusion as a pleomorphic adenoma. Maybe just be careful that adenocystic carcinoma can mimic pleomorphic adenoma in some times. Okay, so this is sweet cheese and stove, charcoal stove, which again pathologists always compare things with morphology. So this sweet cheese and stove charcoal compared to the pattern of growth in adenocystic carcinoma, the cruciform pattern. Okay. Now we go to the last case. Actually, this is case 9. Sorry for the mistake. 28-year-old female with a right parotid mass and FNA was done. So this is the cells. Yeah, again, look very uniform, very bland looking, and I think it's a little bit ill-defined border. And there's a matrix, look like fibrillary matrix. Again, this case I did pleomorphic adenoma, suggestive of pleomorphic adenoma on cytology. But it turned out to be mucoepidermoid carcinoma for this case. So, yeah, again, the lesson learned in this case, yeah, I just want to compare cytology feature between pleomorphic adenoma and mucoepidermoid carcinoma. Again, for architecture, for pleomorphic adenoma, you have a loose cheese and syncytial pattern of cells with fuzzy borders. While mucoepidermoid carcinoma, the cell tend to be more cohesive, not adhesive, loose arrangement like pleomorphic adenoma. And each cell group has well-defined borders, which I will show you later for this case. This was my big mistake, this case. And the matrix for pleomorphic adenoma, both myxoid matrix and leukoid matrix can have a fibrillary background, but the different feature is that for mucoepidermoid carcinoma, the matrix and the cells are completely separated from each other, while the matrix of the pleomorphic adenoma myxoid matrix, they usually blend with the cells, tumor cells. And the main cell component for pleomorphic adenoma, usually they have plasmacytoid, spindle cells, and for mucoepidermoid, the cells look different. They are polygonal. They have epidermoid cell, intermediate cell, and mucus cell. So I show you this case. See, when I got surgical specimen, I went back to review the cytology again, and I found that the cells not similar to pleomorphic adenoma. You can see it look polygonal shape, which is not typical, not the morphology of pleomorphic adenoma. And when look closely, because this case I made very quick diagnosis. When I saw the myxoid materials, I was very confident this is pleomorphic adenoma. But yeah, be careful. This is the lesson that I want to share to you. Yeah, just always look carefully to the cell component. This you can see the cell component. This the mucus cells and pleomorphic cells, and they look very cohesive. The border of the cell look sharp. And you can compare between the pleomorphic adenoma and the matrix. You can see the pleomorphic adenoma. Usually you see myoepithelial cell blend with the matrix. Why for this case only the myxoid, and I think the mucoid look fainter compared to the myxoid. Yeah, but the key point is that they contain no cells. Look at the cells morphology. For the left side, pleomorphic adenoma, you see spindle shape, plasmacytoid, and loosely cohesive. While for the mucoepidermoid, they look more cohesive with a polygonal shape, sharp border, and a mixture of different kinds of cells. Okay, so this is the lesson learned. You should look carefully for the cells arrangement and use the features that I showed you previously to make a distinction between pleomorphic adenoma and mucoepidermoid carcinoma. Okay, so this is the street in Bangkok last week. Last week we had former King's birthday who passed away. We regard that the day of his birthday as our Father Day because the Thai people respect the late King Bhumibol as their father. So the street decorated with a lot of light, and this is on the upper image is Grand Palace. Okay, my last slide, I would like to emphasize that to make the diagnosis for pathology diagnosis is very crucial for taking care of the patients. One of my friends always said to me that, you are a pathologist. I think you are like a Supreme Court because your final diagnosis is like a final verdict to the patient. The patient, your diagnosis can determine the life of the patient. So I think because of how important we are, so we have to make a correct diagnosis as much as possible. So to be accurate for your diagnosis, you need a lot of things. You need to have more experience. You need to see a lot of cases. You need to attend this meeting. To listen to other colleagues to share their experience, and also the multidisciplinary approach. You have to collect as much information as possible to make diagnosis. Like some of the cases that I show you, because of the medical past history that made lives more easy. Thank you.